So today's session is sponsored by the Division of Pulmonary and Critical Care Medicine. We are pleased to have Dr. Sally Wenzel from the University of Pittsburgh here. Today's title is The Approach to Severe Asthma in the Age of Precision Medicine. I'm going to turn it over to our division chair, Dr. Patrick Symptom, to give formal introductions of a former colleague. Thank you all so much. Appreciate it.
Great, thank you so much. So I just want to again welcome everyone to today's medical grand rounds. I have the real pleasure and honor of introducing Dr. Sally Wenzel. Dr. Wenzel is a professor of medicine and immunology. She's the Rachel Carson Chair in Environmental Health, Chair of the Department of Occupational Environmental Health, as well as the Director of the University of Pittsburgh Asthma Environmental Lung Health Institute. To give you a little bit of Dr. Wenzel's background, she completed her bachelor's degree as well as medical degree at the University of Florida, followed by an internship and residency at Wake Forest, and a fellowship in pulmonary medicine at the Medical College of Virginia. So she may be very familiar to many of you within pulmonary and critical care. Dr. Wenzel has really dedicated her career to understanding the pathogenesis and phenotypes of asthma, really with an overarching goal of developing new therapies for those who are living and suffering with severe forms of asthma. She's really been on the leading edge of developing the definitions and guidelines for severe asthma and served as the chair of the original ATS workshop, as well as developed the guidelines, the ERS ATS guidelines. She's considered an international thought leader in the field of asthma, and her studies, particularly in the area of asthma phenotypes, really have been instrumental in us understanding the complexities of asthma. She's been very well funded by the NIH and has been a prolific scholar, publishing over 300 manuscripts in many high-profile journals such as New England Journal of Medicine, as well as Lancet. And of course, she's been the recipient of a multitude of awards, and I'll just highlight a couple, including the ERS Presidential Award, the ATS Scientific Achievement Award, and the Elizabeth Fitch Award. I really want to thank Sally for taking the time out of, I know, her very busy schedule to join us. It's a real honor and a pleasure. And I'll turn it over to Dr. Wenzel. Thank you so much, Sally. We appreciate it.
Well, thank you so much for that very kind introduction. It's always fun to go back to some of your roots, which clearly VCU and Richmond are parts of my roots. And it's very nice to share at least some overlap with the various institutions with your current leader. So anyway, it's great to be here, and thank you very much for the invitation. So yes, I'm going to talk about severe asthma and really how it's changed, how the approaches to severe asthma have changed dramatically since I was a mere fellow at VCU back before probably most of you were born. These are my conflicts. I don't think they're going to impact my talk in any way. But I think before we sort of dive into the molecular aspects of severe asthma, it's really important to kind of put things in perspective. So difficult and/or severe asthma are patients with poorly controlled disease, make up probably somewhere between 5 to 20% of all the asthmatic patients in the United States. That's somewhere between 1 and 5 million people. So a large number of people. Close to 30% of adult patients in a random telephone survey said they had at least 2 oral corticosteroid bursts in the previous year, which is just astonishing to me, especially given the plethora of good asthma medications that we have available. And I think it's important to note that when I look through my EMR and I follow what happens to a patient who goes to the emergency room or whatever, and how that visit is coded, that patient is often coded as a mild or even a moderate persistent asthma patient, despite the fact maybe they've been in the emergency room 3 or 4 times in that last year. That's not mild or moderate persistent asthma. So I think there's clear confusion between what is asthma control, what is asthma severity, what are the definitions of these? So how do we begin to make sense of the noise? Well, in fact, we have to come up with some definitions. And I've, as Pat sort of pointed out, have been really part of the development of guidelines for asthma and severe asthma over many years. And in 2013, combined with the European Respiratory Society and the ATS, we published an umbrella, what I call an umbrella definition of severe asthma. And that is severe asthma, which is asthma that requires treatment with high doses of inhaled corticosteroids. And we're really talking about 1,000 micrograms of fluticasone or equivalent, plus a second controller, things like leukotriene modifiers, like long-acting beta agonists or systemic corticosteroids to prevent it from becoming uncontrolled or which remains uncontrolled despite this therapy. Now that's truly an umbrella definition. That covers a whole lot of people. And in fact, asthma itself is an umbrella definition if we think about it. Asthma basically are patients who have reversible airflow limitation in the face of asthmatic symptoms. And this is really along the lines of many other umbrellas that we use in our medical armamentarium, including acute lung injury, arthritis, congestive heart failure. All these are really umbrella definitions, and they really don't tell us anything about the underlying biology or pathobiology that contributes to those clinical conditions. So once we have this definition, then I think we can start to outline an approach to trying to understand these patients, first clinically, then biologically and pathologically. So the ERS ATS guidelines from now almost 10 years ago laid out the steps to identify a patient with severe asthma. And the first step is to confirm an asthma diagnosis and to identify the patient as having difficult to treat asthma. This is probably the most important step because many patients may not even have a diagnosis of asthma. The second step is to differentiate severe asthma from milder asthma. Will they improve with better education, adherence, treating some of those even non-pulmonary related things? And then finally, to determine whether the severe asthma is actually controlled or uncontrolled. So as I said, this first component is probably the most important. Confirm an asthma diagnosis and identify the patient as having difficult to treat asthma. So asthma requires reversible airflow obstruction. That requires performing spirometry. You cannot diagnose asthma definitively in an adult without showing airway obstruction on spirometry. That is reversible to about 12% or more and about 200 mLs or more in total volume. Again, that requires objective evidence. It's not a diagnosis that you can make in the clinic without doing spirometry. It either requires this reversibility component or hyper-responsiveness, which I'm not going to get into here, but requires a non-specific airway challenge with something like methacholine. It's very important as part of this process that you exclude other primary diagnoses, including the presence of irreversible airway obstruction. I can't tell you how many times I see patients in the clinic who have a diagnosis of asthma who do not have any evidence of reversible airway obstruction. It's important to remember that if there is obstruction and there is reversibility, it does not have to return to normal to still be asthma. There's, again, many misperceptions of a patient who comes in with an FEV1 of 60% of predicted. Their bronchodilator response gets them to 75% of predicted. That's not normal. And so they get labeled as COPD. That's not COPD. In the absence of at least a 15-pack year smoking history, difficult severe asthma is not COPD and should not be coded as such. There has to be a prominent smoking history. Up to 30% of patients with an asthma diagnosis do not meet the asthma physiologic definitions that have been laid out for years. This 12% reversibility is not a new factor in the diagnosis of asthma, and yet 30% of patients with the diagnosis of asthma don't meet that. I think when you see a patient with severe asthma, it's important that a patient should in fact be evaluated and treated by an asthma specialist for 3 or more months. And I think this is especially important now in the age of biologics. These are incredibly expensive medications. They really have to be utilized appropriately in the right patients. And oftentimes this can be pretty complex for a primary care physician to truly understand which is the best biologic for the best patient. And even sometimes the specialists don't understand that. So the second point is to differentiate severe asthma from milder asthma that will respond to various other non-asthma medications. And again, as I started out, severe asthma is asthma, which requires treatment with these high doses of medications. and to prevent it from becoming uncontrolled, or which remains uncontrolled despite this therapy. Patients have to be appropriately treated to meet this definition. And in fact, you're going to have many people who will have difficult to control asthma, but when you treat some of these underlying factors, all of a sudden, they don't require the massive amounts of steroids that they've been given. They actually respond to the treatment of these other factors. So how do you move difficult to control to easier to control and thereby not severe asthma? Well, you need to address reversible associated factors, and probably gastroesophageal reflux disease is the easiest to address and to cure. Now, I don't think there's evidence to really suggest that GERD drives asthma, but GERD drives symptoms that are very similar to asthma from the standpoint of cough, maybe even some postnasal drip sinusitis related things. And it's a pretty easy disease to treat. Smoking, obviously, is always a confounder in patients with difficult to control asthma. And the data are very clear that smoking just makes any type of asthma more severe. Persistent allergen exposure, things like having a cat when you know you are very allergic to a cat. Anxiety, chronic rhinosinusitis, not so easy to treat, even though we have a lot of antihistamines and nasal sprays. Still not a very, very easy factor to treat, but certainly doing the combination of nasal rinses with a nasal steroid will decrease the postnasal drip often to a great degree in patients and make their symptoms associated with their asthma much less severe. And then, of course, obesity, which I think has obviously increased across the nation and the world over the last 30 years, and probably contributes to the symptoms that are associated with asthma. It's still difficult to say how much obesity is driving asthma. And then, of course, you want to confirm and reconfirm the appropriate use of asthma medications at each visit, because certainly adherence is still going to be something to discuss in great detail with the patient at literally every visit. And certainly difficult asthma and even severe asthma have long been labeled as a disease of poor compliance, that it's the patient's fault that they're not getting better. But when you have a patient in front of you with difficult asthma, I think it's very important to go through, if they're having problems with adherence, what are the reasons? Why for this specific person is it so hard for them to remember to take their medications? Sometimes they don't like taking inhaled medications. That's not uncommon. Certainly in younger people will complain, I want to feel strong, I want to feel normal. Medications are a crutch. I don't want to take these because I feel like I'm becoming dependent upon them. Medications can be very expensive, especially some of the combination therapies. Now that's getting a little bit better, and we actually now do have generics that are available, which are coming down in price. But even some of the generics are still pretty expensive. Patients sometimes forget. How good are you at remembering to take a pill twice a day? I know that I often have problems taking an antibiotic twice a day, and again, for a short-term period of time, I'm good at it for 5 days or so, but then by that 6th day, I'm kind of forgetting, did I take my morning pill, etc. And then finally, in severe asthma, the medications might not actually work. And I think this is something that patients need some sort of feedback, like they're getting better when they take their medications. And if they're getting no feedback at all, I think it certainly can interfere with adherence as well. And then, of course, taking inhaled medications, but not using the devices correctly. And we all know that the pulmonary world is loaded with multiple different devices now to deliver inhaled medications, and all of them require a slightly different approach. Interestingly, I think it's very important to point out that perhaps we're at the edge of a new age where adherence help is actually on the way. And I think there's good evidence now to suggest that mild to even some moderate asthma can be treated with PRN combination therapy. Now, PRN implies symptom-driven use of a reliever medication, as is currently done with albuterol. But I'm not suggesting that you're going to treat patients with albuterol. Multiple studies have compared this approach to daily maintenance therapy and showed equivalent or better results with a combination of a long-acting beta agonist and a inhaled corticosteroid. And I'm going to go into a little bit more detail on that. Not the long-acting beta agonist alone, not the short-acting beta agonist alone, the combination. And this can be done either alone, just as an as-needed medication, or with daily maintenance therapy. And the GINA guidelines suggest it can be used alone. GINA and NAPP guidelines actually suggest that you can use the as-needed medication with background maintenance therapy. I think this is the biggest and the most important change to the asthma guidelines that we've had in any number of years, probably bigger than all of the biologics that we've introduced for the patients with the most severe asthma. And this is just a diagram from the GINA 2020. And basically what we're talking about is as needed combination therapy of low dose inhaled corticosteroids, maybe even moderate dose inhaled corticosteroids, plus a very specific long-acting beta agonist for Moderol. That is the only medication combination that you can use as both controller and reliever medication. And you can see that basically you can use this probably you can use it at step 1, you can use it at step 2, and you can probably even use it at step 3 and step 4 if you're using it both as a controller and as a reliever. So multiple studies support this PRN dosing of this very specific combination type. All combination medications for asthma are not alike. It's the long-acting beta agonist for Moderol that is in the Symbicort or a few generics now finally that are arising with for Moderol and budesonide in them. It is not the most common LABA in the United States. In fact, salmeterol is the most common long-acting beta agonist in the United States, which is seen in Advair and Breo and the various generics, Erduo, Wixela, all those have salmeterol in them. Only for Moderol can be used as both a quick reliever and as a long-acting beta agonist. And I think the data are very clear that when they're used, when this combination of formoterol and budesonide is used as a PRN drug, it reduces exacerbations and improves symptoms as compared to albuterol alone. And this is from one of the more recent papers in the New England Journal of Medicine, looking at patients with mild to moderate asthma, looking at exacerbation rates per year in patients that were treated with albuterol alone, or in those patients that were treated with budesonide maintenance alone, or those that were in the combination group using the budesonide formoterol as a reliever medication only, so only using it as an albuterol-like drug. And I think you can see there's a really dramatic reduction in exacerbations when you're using the combination therapy as your control as your reliever medication. And again, you can look at that by annualized exacerbation rate or number of severe exacerbations. There still is a dramatic reduction. So again, moving asthma into a space where patients can take their medications as needed and actually still get the same results. So the last step in defining patients with severe asthma is to determine whether their asthma is controlled or uncontrolled. And there's 4 ways that you can do that, define controlled or uncontrolled. The first is the level of symptom control, and that's either done by asthma questionnaires or really just by your general questions of whether they're really requiring regular beta agonists. Are they waking up at night? How short of breath and limited are they in their general day? Are they having frequent severe exacerbations? And this means 2 or more bursts of systemic corticosteroids of greater than 3 days each in the previous year. Have they had a serious exacerbation? Have they had at least 1 hospitalization, ICU visit, or mechanical ventilation in the previous year? And then finally, is there evidence of chronic airflow limitation with an FEV1 lung function testing of less than 80% predicted in the presence of a reduced ratio indicating obstruction following a medication withhold? Any one of those qualifies a patient as having uncontrolled asthma. And of course, an uncontrolled patient with severe asthma is certainly the most concerning of the patients that we deal with. So when we're seeing a patient in our clinic, and this could be a primary care clinic or a specialist clinic, I think it is important to have an approach to seeing these patients. And of course, as we're seeing these patients, it's really important to put a lot of pieces together. And so it's very important to think about adherence, comorbidities, are there nasal polyps, and is there chronic sinusitis, is there gastroesophageal reflux, and other risk factors, are they smoking, et cetera. All of those things have to be in your mind as you're beginning to see this patient. But I think one of the most important first steps is to really get good lung function testing and to look at spirometry to measure FEV1. And of course, the first step is just going to be your baseline measurement of FEV1, ideally after they've withheld their albuterol, and you're going to determine whether there's evidence of obstruction or not. And obstruction means basically that there is a low age-adjusted FEV1 to FVC ratio. It's not only the FEV1% predicted. And then the most important factor now is to determine whether there is currently or previous evidence of reversibility of that airway obstruction. And again, reversibility of 12% or 200 mLs. If you have this combination of effects and you've addressed adherence, comorbidities, and other risk factors, you have, in fact, a diagnosis of severe asthma. Seems pretty easy, pretty straightforward. But of course, that's often not the case. You will often see patients who you don't see reversibility the first time you actually evaluate these patients. And I think these are patients who really benefit from repeat testing, either during symptoms, a symptomatic phase, or tapering of medications. And if you find that those patients are never obstructed and never reversible, then those patients don't have asthma. And you really need to move them on to a different approach, but not continuing to treat them as asthma patients. But it is important to repeat the testing. And it is important to consider that patients who are symptomatic should really, as adults, almost never have normal lung function testing. If they have normal lung function testing and symptoms, you almost certainly do not have a diagnosis of asthma. So again, this is still talking about generalities. This is still talking about patients with a clinical diagnosis of asthma or severe asthma. In 2022, we can do better than that. We can start thinking about molecular phenotyping. And of course, this whole process started, 10 or 15 years ago with the identification of clinical characteristics that identify particular patients with asthma. And these were things like nonspecific signs and symptoms like obesity, exacerbation prone, fixed airway obstruction, eosinophilic asthma. Those alone do not give insight into underlying causes. And then more recently, we've actually added some molecular phenotyping to these characteristics. And that means adding genes, mRNA, protein expression. But if we do that without context, it's really also not very helpful. You really need to think about these integrating pathways of both molecular pathways, genetics, clinical symptoms, physiology. It's the integration that actually identifies a phenotype of asthma. And when you start merging clinical and molecular characteristics, that's where you can begin to define a molecular phenotype. And in 2022, this is even now further enhanced by responses to our targeted biologic therapies. And this is what I think has really accelerated understanding of asthma and severe asthma in particular, is because these targeted therapies are not dissimilar to knock out mice and taking out a pathway and determining what the effects are downstream of that pathway. So in 2022, I think we have moved in the direction of having available type 2 biomarkers. So type 2 biomarkers, what do I mean by type 2 biomarkers? Well, I mean type 2 biomarkers that can be measured in the clinic, things that are easily accessible. And the two things that are easily accessible are exhaled nitric oxide and blood eosinophils. And of course, exhaled nitric oxide is produced by an enzyme in the airway epithelium known as inducible nitric oxide synthase. That we know is driven by stimulation with type 2 cytokines, particularly IL-4 and IL-13. Blood eosinophils are very tightly regulated by IL-5, and IL-5 causes migration, causes differentiation of eosinophils from progenitor cells, and maintains their survival once they are generated. So again, very important relationships of the biomarker, either nitric oxide to IL-4 and IL-13, or eosinophils to IL-5. Now, eosinophils, we know, actually are a pretty good biomarker. They predict the response to corticosteroid treatment, again, the gold standard treatment for asthma for many years, and they predict exacerbation risk. So this is this first graph on the left here is from a sputum study that was published 10 years ago already, that took patients with asthma in a NIH-sponsored clinical trial system who'd had multiple sputum inductions. And sputum is a way to measure the amount of eosinophils in the lungs of people with asthma. And they divided the patients into those patients who had eosinophils in their sputum every time they measured them, who had no eosinophils ever in their sputum, and those who had eosinophils some of the time in their sputum. And then they looked at their response to inhaled corticosteroids in the clinical trials. And I think you can see that those patients who had eosinophils had a really nice, good, robust response to inhaled corticosteroids. Those patients who had no eosinophils really had no response to inhaled corticosteroids. And in fact, those patients who had eosinophils some of the time seemed to have kind of an intermediate response. They all met the definition of asthma, however, because when you gave them a bronchodilator, they all reversed beautifully. So they had asthma, but only those people who had eosinophils in their sputum at some point in time actually had a response. Now, I also said that they predict not only response to treatment, but risk for exacerbations. And this is actually looking at blood eosinophils. This is from a very large database from the United Kingdom, where the patients with asthma were divided into the level of eosinophils in their blood, in a CBC, in a simple CBC and a differential. And you can see that there's a range of eosinophils in the blood from 200 to 1,000. But you can see as your eosinophils increased in the blood, so did your risk for exacerbations. So identifying patients with high eosinophils in the blood can again serve as a very widely available biomarker to help understand both responses to treatment and risks for exacerbations. Now, fraction exhaled NO, or FeNO, isn't quite as widely available. It's available in many specialist clinics. It's still not paid for by all insurance, but I think we're starting to see an improvement of that. But it's measured in exhaled breath, and it requires a specific monitor to do that. One can see high levels of this gas across a spectrum of asthma severity. Interestingly, it appears to be a very good marker in people that are on systemic corticosteroids of being systemic corticosteroid dependent. So if you have high levels of exhaled nitric oxide and you're on oral corticosteroids, it's going to be very difficult to get that person off of oral corticosteroids. We do know that it is a very specific type 2 biomarker, as it is induced in culture by IL-4 and IL-13 in airway epithelial cells. And it both predicts response to IL-4 receptor blockade, biologic therapy targeted to the IL-4 receptor, and it responds or declines with treatment. So this is, I think, one of the first studies that showed the relationship of exhaled nitric oxide to the IL-4 receptor pathway. This was done in patients with moderate to severe asthma who were treated with either placebo or dupilumab, the monoclonal antibody to the IL-4 receptor. And what you can see is in these patients who were on medium to high dose combination therapy, as you started treatment with dupilumab, there was a very nice 40% reduction in exhaled nitric oxide. Then all the background medication was tapered off. When you were on the dupilumab, there was no change. The exhaled nitric oxide stayed down. In those patients who were on placebo, you can see that the exhaled nitric oxide rose, as would be expected since inhaled corticosteroids typically suppress it. But what was most important was there was a correlation of exhaled nitric oxide with FEV1 or lung function. So that the greater the decline in your exhaled nitric oxide, the greater the improvement in your FEV1, suggesting that there's a biologic fit there. When you block the IL-4 receptor, you actually have an impact on exhaled nitric oxide, you have an impact on the airways that leads to improvement in lung function. So I think with this sort of background in mind now, we can define our severe asthma umbrella into two smaller parasols, what I call parasols. So here's our severe asthma umbrella. Underneath it, you've got people with symptoms, exacerbations, changes in lung function. But we can now divide the patients into those who have evidence for type 2 inflammation or little or no evidence of type 2 inflammation. And we define those patients with a type 2 high asthma as having evidence of reproducible biomarkers, things like blood eosinophils, exhaled nitric oxide, which would predict response to treatment. Unfortunately, on this other side, we still don't have any biomarkers to define type 2 low asthma. But we do know that you should measure the type 2 biomarkers, just like lung function, several times before you say that this person does not have any evidence of type 2 inflammation. Sometimes it takes measuring blood eosinophils 3 or 4 different times and with symptoms. I can't underemphasize the importance of measuring things with symptoms. So even with this breakdown now, I think, into type 2 high and type 2 low asthma, we now know that not all type 2 high asthma is the same, that there are probably multiple different phenotypes of type 2 high asthma. And I think there's been increasing evidence to suggest that defining patients by when they got their disease is actually pretty helpful. And that's such a simple thing. Again, we can all ask our patients, when did their symptoms of asthma start? It's important to ask it in a pretty directed sort of way, but we can understand when a patient's symptoms started. So this was a analysis of 350 patients from the Severe Asthma Research Program, which I've been involved with now for 20 years or so. These were patients who had bronchoscopy, so we had all sorts of clinical parameters, we had inflammatory immune parameters, we had lung parameters, et cetera. And we used all of these characteristics of these patients, and we performed phenotyping, we performed clustering of the patients. And with that clustering, we were able to identify actually 6 different clusters of patients. The first cluster here is basically healthy controls, but 5 different clusters of asthma patients. And what we found was there was a difference in the age at onset, but there was a consistent group of patients who had their disease in early onset in life, so before the age of 12. And if you looked at these patients in relationship to their allergic skin reaction, so allergy skin testing, what you found was these were people that were pretty allergic. So there seemed to be this relationship between atopy and the early onset of disease. And then if we looked at the asthma symptoms caused by potentially allergies to various things, the most specific question that we can ask is, do you have asthma symptoms when you're around a furried animal? I think you can see that the group that had high levels of skin test reactivity, early onset disease, also had the greatest percentage who said, yeah, I get asthma symptoms when I'm around a furry animal. And these patients all had modest elevations in exhaled nitric oxide, blood eosinophils as well, but really consistent with a type 2 process, but not a dramatic type 2 process. Interestingly, they also had the strongest family history. So these are patients who family history seems to predict the development of asthma in this early onset group of patients. Well, how does these clinical patterns, can we start to relate these clinical patterns to again, molecular patterns? And so we know that type 2 high asthma is associated with high levels of exhaled nitric oxide. So this is actually from a study that we published now 8 years ago, looking at epithelial gene expression. Epithelial gene expression in a range of patients with asthma from mild to severe and some healthy controls, and actually looked at the genes using the old-fashioned microarrays that were correlated with that type 2 biomarker, correlated with exhaled nitric oxide. And strikingly, I think we were able to identify 5 different groups of patients on the basis of the pattern of these expression of these genes that were related to exhaled nitric oxide. And I think you can see here that there really is pretty much of a checkerboard. The gene expression pattern is dramatically different when you look at these genes that are related to exhaled nitric oxide. And in fact, we found one group that had low exhaled nitric oxide levels, and really was mostly healthy controls and mild asthma patients. But there was another group of patients who also had low exhaled nitric oxide levels, who actually had 50% were moderate to severe asthma patients. These had very long duration of disease. They were atopic, as you might not have expected given their low exhaled nitric oxide, and they were identified by having high lymphocytes in their BAL fluid. And then, of course, we found 3 clusters of patients that had high exhaled nitric oxide with quite different gene expression patterns, despite the fact that they all gave you high levels of exhaled nitric oxide. And this first group that I'm highlighting here is this cluster 5. These were the youngest patients. They had early onset disease. Half were African Americans. They had very strong family history, the highest IgE, kind of your typical allergic asthma kind of patient. But then we had another group of patients, very dramatically different in their gene expression profiles. Early onset disease, again, mostly severe patients, low lung function, high eosinophils in the blood and the BAL fluid. And then finally, the cluster 3, which also had high exhaled nitric oxide, but again, different gene expression pattern with a much more complex inflammatory process. And here's where you saw patients who had nasal polyps, sinus surgery, and not specific elevations in eosinophils. So this is kind of mixing now the clinical situation with the molecular situations, but now we've got another tool. Now we've got another tool, which are the biologics that are available for the treatment of asthma. And I think this story started now really 25 years ago with the first studies that were done with anti-IgE, omalizumab. And IgE, of course, has been related to allergy and atopy for many, many years now, since it was first discovered at National Jewish before I got there. And I think this, not surprisingly, anti-IgE was first studied in allergic responses, and it was studied in allergic responses in mild asthma. So this graph on the left is a study where patients, is based on a protocol where patients with allergies inhale something that they're allergic to. And if they have an allergic asthmatic response to it, they will have a very immediate fall in their lung function that occurs within minutes of inhaling this allergen. Within an hour or two, they return close to their baseline, and then 4 to 6 hours later, they have what they call a late asthmatic response. So that's what you see on placebo, or you see at baseline. But when these patients were treated with omalizumab, you can see that there was about a 50% reduction in that immediate response, and a really very strong, almost 90% inhibition of their late asthmatic response. So this was really good. We were going to be able to treat allergic asthma, and we would use IgE as a biomarker to predict the responses to anti-IgE. But let's hold on a minute. Let's talk about severe asthma, which is really where the biologic medications only can use because they are so expensive. So this was a study now published 10 plus years ago, which looked at anti-IgE in patients with what we've defined as severe asthma on high dose combination therapy. And in fact, when you look at this group of patients with severe allergic asthma, they had elevations in IgE and positive skin tests. There really was a pretty small reduction in asthma exacerbations, really about a 25% reduction in asthma exacerbations when you were being treated with omalizumab. And total IgE was not predictive of the response to therapy. But in a follow-up study, a post hoc analysis, they said, well, maybe IgE is not such a good biomarker, but what about these emerging type 2 biomarkers? What about exhaled nitric oxide? What about blood eosinophils? And in fact, when they divided these patients into those individuals who had low levels of exhaled nitric oxide versus high, low levels of blood eosinophils versus high, those patients that had high levels of type 2 inflammation were the patients that responded the best to omalizumab, had the greatest reduction in asthma exacerbation. So again, consistently showing that these type 2 biomarkers that are really pretty easily available are pretty good predictors of response to therapy. But IgE is kind of downstream in this pathway. So what happens if we go upstream? What happens if we go upstream of IgE? And of course, upstream of IgE are the canonical type 2 cytokines, IL-4 and IL-13. And IL-4 and IL-13 are well known to generate, well, IL-4 is known to generate Th2 cells, and Th2 cells are very important in the isotype switching of plasma cells to generate IgE. So clearly there's a relationship with allergic responses. But the type 2, the IL-4 receptor pathway is actually pretty complicated because it includes two different types of receptors, a type 1 and a type 2 receptor. And this type 1 receptor is primarily found in immune cells, again, very strongly related to IgE pathways, as is IL-13. And this type 1 receptor only responds to IL-4, whereas the type 2 receptor responds to both IL-4 and IL-13. It has a different heterodimer. It forms a heterodimer with the IL-13 receptor alpha, and it's much more commonly, more broadly distributed on inflammatory cells, on structural cells, on B cells, on smooth muscle cells, et cetera, than is the type 1 receptor. So a drug was developed, dupilumab, which actually is a monoclonal antibody to this IL-4 receptor alpha, which blocks both of these, both the type 1 and the type 2 receptor. And we know from some early studies that when you inhibit this IL-4 receptor, you decrease IgE and you block inhaled allergen challenges. So it, again, proves that it, in fact, is upstream of IgE and allergic responses. But unlike the IgE story, when you now take this biologic into more severe types of asthma, you actually can see a pretty robust improvement in asthma exacerbations as well as in lung function. And these are data from the phase 3 study that was published now 4 years ago with dupilumab, looking at patients and dividing them by their type 2 biomarkers from those individuals with very low levels of blood eosinophils to high levels of blood eosinophils, low levels of exhaled nitric oxide to high levels of exhaled nitric oxide, and then looking at their relative risk for an asthma exacerbation as compared to placebo. And I think you can see that when you look at blood eosinophils, if you have low blood eosinophils, you're not likely to respond to this drug. But as your eosinophils increase, you see an improvement in exacerbations. The same story holds with exhaled nitric oxide. Low exhaled nitric oxide probably don't respond, but with increasing levels of exhaled nitric oxide, you do see an improvement. And again, this supports that blocking this type 2 pathway in patients with more severe asthma actually is effective in reducing asthma exacerbations and in lung function. Now, I've alluded to the fact that allergic type 2 high asthma is probably not the only type of type 2 high asthma. That is more complicated than that. And the second most obvious group of patients are those patients who, in fact, got their disease later in life. These are patients who have late onset type 2 high disease, often associated with nasal polyposis and severe asthma. So as I showed you before in this clustering design, the majority of people actually got their disease early in life, but there was another group of patients who got their disease much later in life. And when you looked at their relationship to allergic skin reactions to atopy, they had very low levels of atopy, unlike all the other groups. They had high levels of nasal polyps in relationship to their asthma, and they had persistent evidence of elevated type 2 inflammation. these patients are vastly clinically different from early onset patients. The relationship to allergic asthma reactions when they're around furred animals was almost absent. And again, consistent with their lower levels of atopy. So this association, this late onset nasal polyposis related asthma, related severe asthma, is very strongly associated with eosinophilic inflammation. So we're going to move a little bit from exhaled nitric oxide and talk more about eosinophilic inflammation. Well, it's not surprising, since eosinophils have been associated with asthma for 100+ years, that one of the other early targets was targeting eosinophils, and anti-interleukin 5 was one of the first antibodies to follow the anti-IgE approach. Well, interestingly, back in 2000, they used anti-IL-5 in that same allergic asthma model that I showed you with anti-IgE, and it didn't work. Did nothing in that model. And it really almost died on the vine, and for 10 years, nothing happened with it. And then a group in the UK said, well, why don't we target patients who actually have evidence of eosinophils? And so they did. They recruited patients with eosinophils. And when they used the drug anti-IL-5 in these patients with eosinophils, there was a pretty profound 50% reduction in exacerbations. And over the years, that ability to identify the patients that respond to anti-IL-5 has really become pretty consistent. And so patients who have elevations in eosinophils around 300 to 400 cells per milliliter are those patients who seem to best respond to anti-IL-5 approaches to therapy, or anti-IL-5 receptor approaches to therapy. And almost all of these drugs give you about a 50% reduction in asthma exacerbations, with a more modest impact on things like lung function and asthma symptoms. But again, very consistent reductions in exacerbations. But surprisingly, these patients don't work the same in all patients with type 2 high inflammation. They seem to work the best in patients who have fairly severe disease, those patients on oral corticosteroids, those patients who have late onset disease after, in this case, the age of 18, or those patients who have evidence for nasal polyps. They don't perform. Anti-IL-5 does not perform very well in patients with early onset disease and allergic asthma. So if you're really considering what's the best biologic to use in someone who is a highly allergic asthmatic, anti-IL-5 is probably not your best choice. Now, anti-IL-4 receptor antibodies also seem to work very well in late onset nasal polyp associated disease. And in fact, anti-IL-4 receptor antibodies were the first targeted therapy to be approved for the treatment of nasal polyps. This is one of the earlier studies with dupilumab in patients with nasal polyps. And again, I think you can see that in the patients who had a history of nasal polyps, there was really a very profound improvement in FEV1. There was a very profound improvement in symptoms, really above and beyond what you saw in patients with early onset disease. And now, again, the dupilumab is approved for the treatment of nasal polyps, supporting a role of the IL-4, IL-13 pathway. In addition to their improvement in asthma, there was this improvement in polyp scores and associated symptoms. And I think this really suggests and supports the concept that innate lymphocytes, the more recently described cells that are innate components of the lymphoid system, may in fact be involved as part of an endotype of asthma, where there's greater IL-5 expression and IL-13 expression, potentially stimulated by some of the alarmins, including anti-TSLP. But those are stories for another day. I also suggested that anti-IL-5 worked best in patients who were oral corticosteroid dependent. And these, of course, are the most the most challenging patients that we see. Are these patients really a different phenotype, or are they more of the same? And you know, again, I don't think we fully know at this point, but clearly these are patients who are all, even though they're taking oral corticosteroids, they're still highly symptomatic. Their ACQ scores are very high. They have more than 2 to 3 exacerbations every year for the previous years. And lo and behold, they have a high percentage of nasal polyps. 30% or so of these patients have a history of nasal polyps. So again, there's going to be some sort of overlap with this late onset nasal polyposis, highly eosinophilic disease. And the good news is that these type 2 biologics all seem to reduce oral corticosteroid dose independent patients. And you can look at anti-IL-5, this is anti-IL-5 receptor antibody, or you can look at anti-IL-4 receptor antibodies. Really the effects are basically interchangeable, that there's about a 75% reduction in oral corticosteroid doses, whether you're using anti-IL-5 receptor antibodies, anti-IL-5, or anti-IL-4 receptor antibodies. Really a fairly profound reduction in oral corticosteroids. And I think it's important to point out that eosinophils are still elevated in these patients on oral corticosteroids, and about 30% of them have nasal polyps and late onset disease. So they really seem to be this highly eosinophilic nasal polyposis associated patients, even despite oral corticosteroids, where their eosinophils should be gone. They shouldn't have eosinophils. So the last group of type 2 high patients are those patients who I call type 2 plus. These are patients with severe asthma who meet an asthma diagnosis. We described these patients back in 2012. They're all on systemic corticosteroids. They're typically late onset adult or adult worsening of early onset disease. They typically have high levels of exhaled nitric oxide and blood eosinophils despite systemic corticosteroids. There's often an associated family or personal autoimmune history. And because these patients were so challenging, I decided that we needed to try to understand them better. And so we actually did video-assisted thoracoscopic biopsies on these patients, and with Sam Newsom's help, who has passed away in the last year, we identified granulomas in these airways in about 50% of these patients. And this family history of autoimmune disease, these granulomas in the airways, I think are consistent with multiple new studies which are showing a relationship between asthma and rheumatoid arthritis. And so again, I think we've always thought about asthma as this allergic sort of process, but I think asthma can develop with a variety of immune pathways being activated, including those related to autoimmune disease. This is just a micrograph of the asthmatic granulomatosis patient. This is a small airway. You can see that there's a very thickened airway wall. It's plugged with mucus. There's lots of eosinophils in this airway wall. That looks like asthma. But over here, you see a granuloma. That granuloma shouldn't be there. That's not what we see in typical asthma. And these are patients who seem to benefit from treatment with a type 2 biologic, and potentially with an additional alternative immunosuppressive agent, something like methotrexate, azathioprine, those sorts of things, but more clinical trials are really needed there. So in 2022, I think you can really put forward 4 different subgroups of type 2 high asthma, a group with very mild corticosteroid responsive early onset asthma, really not too much of a worry for anyone. Early onset moderate to severe corticosteroid treated patients who are generally allergic asthmatics who probably still respond to some degree to corticosteroids, but maybe better to anti-Ig or anti-IL-4 receptor antibodies. Another group with late onset eosinophilic asthma and nasal polyps. These are patients who are going to respond best to anti-IL-4 receptor antibodies, anti-IL-5 pathway blockers, and potentially systemic corticosteroids. And then this group over here, which are these very complex patients who have predominant type 2 and type 1 potentially inflammation, where we don't really know how to deal with these folks, and it's likely going to be a combination of approaches. So I just want to close briefly with a little bit of information on non-type 2 molecular phenotypes. Are we making any progress here? We still don't have any biomarkers. It's really unclear what percentage of asthma has no evidence for type 2 pathway activation. And I think, as I tried to emphasize early on, you have to do repeated measurements. And if you do repeated measurements, it's probably likely that only 30 to 40% of asthma patients will have no evidence of type 2 biomarker elevation. And it is certainly going to be dependent on the doses of corticosteroids. IL-6 has been of interest for now 5 or 6 years. And IL-6, of course, is associated with metabolic dysfunction, autoimmune diseases. And in fact, in the asthma population, when you look at metabolic syndrome in relationship to levels of IL-6, markers of metabolic syndrome, you can see that those patients that have high levels of IL-6 in their plasma actually had a greater history of hypertension and a greater history of diabetes, consistent with a metabolic type of process. But is it possible that IL-6 is actually a component of worsening asthma as well? And I think this was a very nice study published now just a couple of years ago, looking at, again, the Severe Asthma Research Program patients and looking at asthma exacerbations in relationship to either plasma IL-6 levels or blood eosinophil counts, something, again, we've associated with asthma exacerbations for a while. And I think you can see that the relationship of asthma exacerbations to IL-6 was actually at least the same, if not a little bit better, with IL-6 levels in the blood as compared to eosinophils. So maybe we're starting to have a new biomarker for type 2 low asthma. And fortunately, the NHLBI now has an adaptive clinical trial network called PRECISE, which is actually studying anti-IL-6 in patients with high levels of IL-6. So hopefully we'll know very soon whether IL-6 is actually relevant to non-type 2 asthma at all. Now, the newest biologic is something called anti-TSLP or tezepelumab, anti-thymostromic lymphopoietin. TSLP is a central innate epithelial alarmin. It really is generated primarily by the epithelial cells, perhaps by monocytes and macrophages as well. It generates IL-5, it generates IL-13. It stimulates ILC2 cells to generate IL-5 and IL-13, and of course those can have all the effects that we've talked about before. There's some very striking data that suggests that when you use anti-TSLP, you can reduce airway hyperresponsiveness, which has been pretty dramatic. And it also decreases eosinophils in the blood. It also was approved for the treatment of severe asthma earlier this year, and really, again, has shown pretty broad efficacy. And one of the things that's very curious about the drug is that it appears to work in patients who are type 2 low as well as type 2 high. So if we divide the patients in these clinical trials on the basis of their blood eosinophils, like I showed you with dupilumab, what you find is even in the patients with the lowest blood eosinophils, there is still an improvement, a significant improvement in exacerbations that gets even better the more type 2 inflammation you have, but is present in the patients that have very little evidence of type 2 inflammation, both from the standpoint of blood eosinophils and from the standpoint of exhaled nitric oxide. So perhaps TSLP is going to be an umbrella sort of cytokine that is actually important in both type 2 low and type 2 high asthma. So as we see this patient in our clinic, again, we return to the practical approach. I think one of the first things that we're going to try to do is determine, is there type 2 inflammation there or not? And we're going to do repeated measurements of exhaled nitric oxide and blood eosinophils. And if a patient is on oral corticosteroids and the levels are really low, it's important to initiate a taper of oral corticosteroids. And depending upon whether you identify the patients as having low or high levels, you're going to be left with someone who has refractory type low disease, type 2 low disease, or refractory type 2 high disease. Then you want to integrate age at onset. Are these patients who got their disease before the age of 12 or 18 or after the age of 12 or 18? And so you can divide them into early versus late onset, type 2 low, high, or type 2 high patients with or without nasal polyps. And again, in all of these patients that have type 2 low disease, I think you want to consistently try to reveal whether there is underlying type 2 high inflammation. So I suggest even tapering inhaled corticosteroids in some of these patients. And if they develop elevations in type 2 biomarkers, you're going to follow the early onset or the late onset guidelines for the treatment of type 2 high asthma. But if they have no evidence of type 2 biomarker elevation, these are the patients that, again, fall into this bin of type 2 low asthma. I think these are the patients who really do require considerable more evaluation with things like CRP levels as potentially a surrogate for IL-6, high resolution CT scans. We don't really know what to do with these patients. But these are patients who I would even consider metabolic testing, autoimmune immunodeficiency testing, as well as weight loss. And then for all of these other folks, I think you're really going to follow type 2 high treatment paradigms using the type 2 biologics that we have available to us. And if you get a poor response to those folks, you're going to want to circle back and see if there's additional components of inflammatory processes that are involved in even things like asthmatic granulomatosis. So in conclusion, difficult and or severe asthma are really umbrella terms, with severe asthma being a subset of difficult asthma. Once identified, severe asthma can be easily divided into those with and without evidence of type 2 inflammation, and precision medicine can and should be applied to the treatment of type 2 high severe asthma to improve outcomes. They're not all the same. So thank you very much. These are the various acknowledgements that I'd like to mention right now, and I'm happy to take any questions.
Thank you, Dr. Wenzel. Looks like we have two questions. One from Dr. Renee Carter. So if patients present with classic asthma findings, do we only need to do PFTs if they're difficult to treat, or do we need to do baseline before starting management? Any comments?
I would recommend doing PFTs on every patient with asthma. Every patient with asthmatic symptoms deserves pulmonary function testing. And you'd be surprised how many patients you seem to fit the bill for asthma. Oh yes, they wheeze, they've been in the emergency room, they've been heard wheezing in the emergency room. And you do PFTs and there's absolutely no evidence of obstruction on repeated measures. So yes, please do PFTs early and often.
Thank you. There's one more here in the chat box from Dr. Arjun Mohan. Great talk. Thank you for making the time during your busy schedule. Given our inability to translate the phenotyping knowledge to clinical care and shortcoming of current biomarkers, what do you feel should be the next steps to move the needle of precision medicine in asthma? Expert consensus, prediction scores, combined biomarkers. For example, which patients will benefit from macrolides or LAMAs, or one anti-eosinophilic agent over another, dual biologic in terms of risk prediction, so forth.
No, that's a really good question. And I think there's multiple levels to responses to this. So I think the NHLBI has sponsored this adaptive trial design called PRECISE for understanding various approaches to treating of patients with severe asthma on the basis of some measures of background biomarkers. And IL-6 is one of the drugs, imatinib is another one of the drugs. Anyway, there's a variety of things that will get cycled through. And I think that's going to help us link biomarkers to treatments. But I think as part of this, my guess is we are going to come up with an index, that there's not going to be a single biomarker, that you will measure a couple of biomarkers. And it's really that combination that'll help to point you in the right direction. But hopefully in association with, again, basic physiology, because you've got to have a diagnosis of asthma at some point here, as well as, simple things like, when did you get your asthma? So all of those things together, I think we will come up with some indices that will predict treatment responses.
I think we have one more question. Dr. Brath, are you there? You had raised your hand. You should be able to unmute now if you want to ask a question.
No, sorry. I think I was probably trying to say thank you.
Okay. Thank you. think that's all we have for questions. Dr. Nana Simkin, do you want to close us out with any remarks?
I mean, I think everything that needs to be said has been said. Dr. Wenzel, we really want to just thank you so much for, I think someone just described this as a tour de force, and I concur. This was absolutely wonderful. And we really do appreciate you taking time out of your very busy schedule to be with us. We certainly hope that that you will not be a stranger. Maybe we'll have you back sooner. But we certainly do appreciate you taking the time. Dr. Syme, anything from you?
Beautiful, and thanks so much, Dr. Wenzel. Great to see you.
Thanks, everybody, and hopefully next time in person, and I'll see some of you at ATS.
Absolutely. Absolutely. Great. Well, thank you, everyone.
Thanks, everybody. Bye-bye.
Thanks, everyone. The CME code will be posted in the chat again. This concludes our grand rounds for today. Thanks you, everybody. Have a great rest of the afternoon.